Great. Couple comments and a question. Where do you start first? One of the things I would posit is, has this been framed as a change management project? That's not the right word, but and if so, is it laid out like that? Is it clear what the purpose and the goals are when you then try to develop your communication strategy? Is there, I know there's been a lot of work about where it's going to happen and some of the implementation things, but are those details really worked through as you might do for some other change management things? And it's a question that may or may not be answerable at the moment.
I can make a quick comment, which is that there may not be enough change management folks, but our internal National Center for Organizational Development, much of them have moved to work for the Office of the Electronic Health Record. There is likely not enough folks in there, but they are there's a separate section in the overarching Cerner implementation, and then there's those subgroup that will be, at least there's dedicated staff and not just additional duties as assigned.
So one of the things that might be thought about at some point is when you have that plan laid out, ask some folks who have been involved in change management to take a look at it and to see where it's likely to succeed well or less well. Just independent input is often useful. But another question I had as I was sitting through several of the sessions had to do with data and data analysis. And VA has oodles of data. I'm not sure how well it's used or integrated or connected, but I don't know if anyone can comment on that, and maybe it's not necessary, but at least as a thought, is what are the data sources? What's being mined specifically in preparation for this effort? There were several examples given different sessions about things that had been learned that were applied. I think Mike Davies, you quoted a number about 70% of young males. So obviously, some data is being mined, but a question I would have is enough being mined and looked at and analyzed that would really be helpful in implementing this? And if there are opportunities there, how will that be actualized? Joe?
So I think it's a great question, because I think a lot of times IT implementations, the secondary uses of data around analytics comes after the fact, as the CIO potentially says it's got to be functional, right? I got to get everything up and productivity up and going. I think it's worthwhile to think about some of the products and part of the visioning of what do you imagine that veteran experience to be, and what do we need to be able to get there. There is a lot of new analytic techniques that will say, give me whatever data together, throw it in a lake, and let's see if we can get stuff or surface ideas. I think that's to me, perhaps a little bit more in the research domain, per se. I think there's a lot that you can do if you are knowing what action you're trying to support with the analytics and working backwards and making sure that the system connects. People will say, it would have been wonderful if we just had access to that data, because that's got all this other information that would be really helpful to do this, rather than this is all we've got because that's what we set up, and we're going to try to make lemonade out of those lemons. And so having that forethought, at least in the beginning, again, knowing that this is a multi-year process, and making sure that that thought gets put up front, I think is very, very valuable. It's a lot harder, and I know people try to say, it's okay, technology will catch up, we can merge it all later at the end. It's not quite surfaced in that way. So
and not to beat the change management thing, but change management always starts with what's the problem we're trying to solve, which is kind of where we need to go with data analysis. What are the problems that we need to solve, and then what's the data available that might inform that? And there is a somewhat of a logical process to this. Yeah. John, you were...
Yeah, so where is 100% of the Beth Israel Deaconess data stored? Amazon. Now why? I mean, there's a couple of answers to that. Amazon actually is a very reliable and secure operator of infrastructure. In fact, I could argue Amazon is better than any hospital or healthcare system in the country at operating servers and storage. So we moved it there. But what's the other thing that happens? Once you're in the Amazon cloud, giving analytics companies access to the data that you have in the cloud, which is a lake, turns out to be ridiculously simple. You know, we sign a business associate agreement. We agree on what data they're going to use for what purpose. In effect, it's a DURSA. And then one click, and they have access to it. So what are the kinds of things we did? So we gave Google and Amazon and a few other organizations access to certain data elements. Here's a question we asked. So Eva, who is a very thin person, has an appendicitis. Not really. But she needs her appendix removed. How much OR time are we going to give her? Well, it turns out she's a thin person with no comorbidities, so we can actually remove her appendix in about 20 minutes. As opposed to a person who's a diabetic, who's very large, it's going to be an hour, right? But what do we give in the OR schedule every patient? You get a block, whatever that block is, an hour or something, right? So today, the Beth Israel Deaconess OR schedule is managed by Amazon. And it's based on 1 million patients like you. And what was the outcome of doing that? We have opened up 30% of the capacity of our operating rooms. And it was no change other than let's assign an OR time which is appropriate. And if we're wrong, that's okay, right? We'll just extend the OR time. But she doesn't need an hour. And then what you do is you create a scheduling app, which we did, very ZocDoc-like. We'll call it Open Table for the OR, because you freed up 30% of the capacity. So now a surgeon could say, I'd like a table for 2, appendectomy, 7:30 in the morning, give me a window. And then they schedule literally in seconds. The OR slot that was made available is now used for another patient. And so the end result then is the queues go down, but you haven't had to build any other ORs. I only mention this as an exemplar because this idea, as he said, of planning on creating a data lake which is cloud-hosted and connected to other analytics providers, you may not even know what analytics you're going to need. So that's okay. Just build an agile infrastructure to do that.
So I do echo that, and in fact, at Grady Hospital, that's precisely in the OR. It's dynamically, appointed in terms of the time, and the prediction is exactly using the data from the patient, from your current patient, and you build that history, and you're able to predict really the time, and it works really beautifully. So I think VA has extraordinary amount of data. So I would think that as you march forward with the transformation, this is really the opportunity to transform the quality of care, the efficiency of care, and as I say, providers have to be happy and patients have to be happy, because I think that's really an opportunity there. I like the way that, Ken always talk about change management. But I mean, one of the things that we like to talk about is how much can you change, and also how efficient or how effective you could change, which would be quite different, right? Some people accept the change, and then they could be really ready to exhibit that type of change behavior. But some may not be. So I think that's also a very good exercise for VA at different regions, knowing how will people adopt and adapt to different changes and really document those, because you have such a large system and you cannot start at every single point. So, but I think there's a lot of opportunity. I'm very excited about that. So, and I look forward to really working with all of you.
Susan, you were going to make a comment?
Well, and I guess I have a question really, and that is, in doing some of this work and looking to or seeking what data elements might be most useful, do you really start with the workflows of what's the goal of that workflow, and then what data elements will inform? Because it is really different than care delivery quality data. It's data that will inform the way that the veteran uses, perceives, and engages in their care. So there's just very different data elements than a lot of us are used to working on. So maybe if you guys want to comment on that, I'm really curious if that seems right or not.
I just wanted to comment again kind of more on the basics, and with the purpose of like this also being generalizable lessons for other systems too, is that I think the VA actually does have really good operational data. So the data that you already have, making sure that you'll be able to get that from a new system. Like you're looking at the delay and the demand, your supply, your completed appointments and no-shows, and all of those really important operational things. And that the delay, if that's one of our main goals, is to have access and reduce delay, really understanding that relationship between the supply and demand, that's really what's producing either you have a good delay or a long delay. So I think you do a good job, and I don't want you to lose any of those things in your measurement as we also talk about like more and more sophisticated and granular things. And then something else came up about the stop codes. Like there's a lot of questions that you're asked and you're supposed to provide the answers. And how many PTSD patients did I see last year? I'm worried, maybe not so much for you, but maybe other systems, like their thought process is usually like, oh, if I'm not categorizing that in my supply, then let's just make a visit type, and then I can count all the visit types of PTSD. I know that you're probably not doing that, but that would create hundreds of visit types instead, which is a whole nother problem. So thinking about if you need to answer that question, how many PTSD, who's the person that says this was PTSD, and how can we summarize it? Like, where are we capturing those variables? But trying not to put that up front on the scheduling system, I think, is really important.
So I think I do want to make a comment about, like you mentioned about data and what type of data that we need if we are going to analyze. So I work with the Vision, and it's very interesting because when I go in when I went in, and so they will always ask me, what do you need? And we'll give you everything you need. So amazing is that, like during that process as we work with them, we discover lots of data that is available already and which they do not know. So I think there's also a discovery process that the beauty is that nobody could go into V and say, hey, give me the data, and then I go home and I'm going to do the analysis. It's really a collaborative effort, and I think that's also a discovery effort. Like as we explore, we discover, oh, there's this data that you don't know how to use it, but I know how to use it. So I think that's really like, it's kind of like a parallel discovery process. And you might discover that some of this data is extraordinarily useful to give you characteristics of patient, right, complexity of patient, which you may never even know in the past. So I think that is really the discovery part. And I like people say, oh, tell me what data you want. It's not possible because I think you collect so much data. I don't think all the doctors, if I'm going to challenge all the VA doctors, that you know all the data elements that you have collected. I don't think you know. That is the beauty, right? Because when we actually try to analyze it and investigate, that's when we really find out what are the elements. And then during the analysis process, you discover what elements are more important than the others, right? So that's all these things. And I think that is what the value, it gives you back the information that you want, and then you integrate it within your work process.
Thank you for that. Yeah, that is helpful, actually, Eva.
There's there's a spot there because I think, John would say like storage is now super cheap. It's getting cheaper. And with the shift over into a new system, and I was about to call it centricity, in the Cerner, a lot of things are changing. And I've got to think that probably within the VHA, there is executive leadership cascading down a whole series of KPIs going down, and this new system is going to have to plug into all of that in probably slightly different ways. And so part of the question would be, again, that exercise, if there could be a line of sight in there, you will be able to discover how a lot of the different data sources within Cerner are starting to get aggregated up, and you will probably be able to see what opportunities are there, what new untapped resources. We've never gone into that data over here, because in some ways the enterprise, at least at the executive level, they're going to probably be feeding in almost everything from that system in some way, shape, or form. I don't know where the governance of that is, though, and how your project team fits into that global sort of look, but if it's going to go live in the Seattle Vision, someone's doing that work inevitably right now.
So a quick comment on storage is cheap. I actually have some statistics for you. We spend 25 cents per patient per year. Yeah. So there you go. 25 cents. Are you willing to invest 25 cents in each patient? Yeah, probably. And what Eva said is correct. When we do these machine learning models with Google or Amazon or whoever, we often don't know what variables are the most relevant. And so we tend to actually export most everything. I mean, it obviously can't be absolutely everything, but a generous selection of data, and then we create the models and then refine them from there.
Thank you.
So let me also invite anyone from the audience if comments or questions.
Well, I have two comments I'd like to make that were sort of areas of not aha moments, but sort of reminders about what we really should be doing. One sort of this point that Oliver made about focusing on the patients as the center. I think we talk about it a lot, but I think the way he described, how ZocDoc is doing this gave me sort of a new insight into all the things we could do. And I'm thinking about our current state. We have a patient satisfaction survey that goes out to people. It has questions in it. It's kind of the one question that we have is, how soon could you get your care? And so we end up focusing on that one thing because that's really what we have. I think, Susan, I'm wondering if we don't need to really, as part of the scheduling process, maybe figure out how we can get much richer data, on the patient preferences, on where they want care, types of care, times of care, and really think about how to incorporate that patient experience into us much more real time. I mean, once a year, that one question is very different than what he described, which was basically 1,000 times a day or whatever, So I thought that was really worth noting. And the second thing I would offer from my perspective about this whole thing is what if we did a thought experiment and said, right now our schedules are 30% empty, let's say, probably in VA, and we have this opportunity to fill them up. What if we fill them all up? What if we fill them all up, for example, with face-to-face appointments? All this stuff is successful. I fear that there's going to be burnout of our providers, and they're going to leave en masse because they're in a salaried system. They have a certain expectations about what's going to happen. They can make more money across the street. I think one of the things we haven't really talked about very much is that end of the provider satisfaction into all of this. Yeah, we need to put the patient at the center, and we need to discover demand and match supply to the demand. I get all that. But we also need a system where the provider has control over, I don't need to see this face-to-face. This can be done video. This can be done by my nurse, and put them in control over managing the population in the most friendly and appropriate way that population needs to be managed, and not just sort of fill up the schedule and report to Congress our productivity is higher. So I think there's a whole piece of that probably is worth some discussion at some point.
That sounds like it could be a robust discussion. I wonder whether the question is not whether the docs would burn out if they're seeing more patients, but if they actually had scheduling systems that worked and HR processes that worked and other support systems that worked, whether they might actually be a lot happier seeing more patients.
But one of the things, Ken, I would say is, and I don't know where the VA is in terms of national burnout levels. Does it mimic? My guess is it probably mimics national standards, but a little better. Oh, that's good. You have less burnout. Yeah, so then there's a risk, right, particularly with scheduling systems, because I think scheduling systems is one of the last bastions of control, and control and autonomy is an area that, again, even that Stanford model will say is a big driver of professional autonomy and satisfaction. So what's the balance that's there? So I do think it's a relevant point, and thinking about the models and the sort of the conceptual models that are coming out around drivers into individual clinician burnout, and keeping that front and center as the system around the clinicians are changing. And I would say, honestly, it's the same for nursing. It's the same for a lot of other professional staff, too. So it's not just the physician on this one.
Dr. Lehman.
So Lisa Lehman, Chief Medical Officer in VA New England. So I want to follow up on Mike's important point, because I think that this is really critical as we think about scheduling. And many of the presentations that we had in the last panel were focused on getting the schedule to be 100% full, right? How do we reduce that gap? And I think that I'm not convinced that that's the right question, to be honest with you. I think, and it's not just about provider burnout. I think provider burnout is one dimension of this. I think it goes back to the patient and thinking about what is the right care for this patient and the right modality of care. And what we really need to be thinking about, I think, is how do we incentivize providers to do the kind of panel management for their population of patients that is going to deliver the care that the patients want and that is going to be best for their problems. It's not about filling up your clinic to bookable hours. And so we need to sort of figure out how do we have that agility in our scheduling and change the dynamic so that we're also incentivizing our providers to do telehealth where it's appropriate, and not to be thinking that it's just about bookable hours, because that's kind of the mentality right now. I want to Ken, you really piqued my interest, or my curiosity about the 7 fatal flaws of change management, because I think one of the things that I hear a lot from the front line is that VA is constantly sort of throwing new things at people, and there's the office of the OVAC now has a minimal scheduling effort policy that I think goes into effect next week, and that the field feels like it's still constantly changing, and there's a lot of concerns about how we roll out these initiatives and how many new initiatives are we rolling out at the same time. So I would just encourage you to sort of be thinking about getting the voice of the field more integrated into this work as it moves forward. And I think this idea of, well, what are those fatal? I'd love to just hear what are, in a synopsis maybe, what are those 7 fatal flaws? And I think we just need to do a much better job of change management in our organization, because the challenges of scaling something throughout the country are so great, and we haven't quite cracked that nut, I think, yet.
So in the interest of time, I won't go through what those 7 fatal flaws are. We'll save it for some other occasion. Lisa?
Sure. Thank you. I think this is on. Lisa Arfons. So just, I guess, as an ICEP bookability junkie right now with Susan, I think that you can't have one without the other, that you have to fix bookability as what we sort of term the bottom layer of the cake. And if you don't build that foundation, then everything of it is going to crumble, I think, including all of these initiatives, to be honest. And so I do think that bookability is important. I think what you said yesterday, Dr. Lehman, about changing the culture of how we value our MSAs is also extremely important, and it all needs to be done. And, if you're managing a panel of patients, seeing 6 patients a day, that's also not reasonable for right time, right place, right type of appointment if there's no availability at all. So I think bookability is really, really important, but everything else is also. So we need all of it.
May I make one quick comment, and that is, as it may apply to other systems, we have been pretty provider, physician, or nurse practitioner, or PA centric and face-to-face centric, and it is dependent on location in the country. But we can, sure, if every patient is seeing the provider and the physician or the NP or the PA, and there's not a team to help support that, and there's not a good scheduling system that's efficient or effective and overbooks, at every moment, and you're triple booked in every one of your slots, you're going to be burned out. But I think that there's an opportunity to really use scheduling to push the non-face-to-face visit agenda and the team member agenda. And that infrastructure, I think, will allow or enable us to really maximize the number of patients being seen, right? And because we still are, or maybe we weren't years ago, seen as needing to be really business savvy, but we're at the precipice of sending, people a third, a half of our people into the community where we know in most cases that we're providing better, care for veteran-specific clinical care, or in general, better quality of care has been documented. So I think we have to actually think of how to support the physicians and the providers with systems such as the scheduling system so that they can, see more patients in the VA and be mindful of that burnout factor.
So I do want to make a comment. Is as you remember what Dr. Hu was talking about, the complexity, right? The scheduling. It really is not optimizing just for the sake of maximizing the number of patients. It's precisely the optimization itself truly take into consideration of both the providers as well as the patients. In fact, at the end, Dr. Hu was so happy with his schedule that he, of course, talked to the IT people, and then all the doctors were complaining and said, okay, we must have this. So I think the benefits is both sides. I really see the scheduling part is not, of course, it's patient-centric, but it is the doctors really having the pleasure of seeing the patients and not feeling burnt out, and that their time is fully really valuable face time. I think that's really, or even just telehealth. And I think those, every single minute count. And sometimes I think the current system now is wasting a lot of doctors' time, and that is really the inefficiency that comes in. So I think it's both ways, and I absolutely think that we have to value the providers, because if they're not happy, you're not going to have them, and that part is really important also.
So one other brief comment for any of those of you that are, practicing in physicians or clinicians. If you had a designated patient that was more complex and you had 45 minutes to take care of that patient, but then you had a follow-up patient that needed 15 minutes, I'd be thrilled, actually. I'd feel like that was aligning with the way that I overall are delivering clinical care, and that there aren't no-shows with overbooks. I mean, there is something about the way a clinician is engaging, or if there are opportunities to do telehealth from home, and that exists in VHA, right, Leonie? There's providers that are sitting at home, but we're watching their clinical productivity, and that's a perk. So I think that there are ways to set up the systems to optimize, patient throughput and taking high quality care, but then they're still productive providers and feel supported.
There's one thing, so we were talking about this at lunch too. I think one of the areas that does lead into the burnout space too is that it's not just visit-based activity, right? And so we were talking about you're optimizing. It's not necessarily the clinical morbidity that is driving the work or the work expectations or workload that's created. And we were talking about you can have someone with a problem list 17 items long that could be handled in a 15-minute sort of encounter or a 10-minute sort of just event, versus someone with nothing on their problem list but is someone that generates 17 email messages to you, right? 12 phone calls to your team, and that blows out even if, you're slotting into a visit type overall. So in many ways, the burnout element, which bridges far beyond, we talk about pajama time and all that, it's the overall work that's being generated from those encounters and what you're supposed to do to create value for both the patient as well as the system that I think needs to get optimized a little bit more if you're going to balance that.
Seeing no one else at the microphones and no other last comments, we will give you back 45 minutes of your day. My thanks to all of you for being here. My thanks to my cohorts on the planning committee. My thanks to Dr. Kirsch and VA for funding and supporting and asking the National Academies to hold this forum. Our work is not done, but we're nearing the end. So thank you all. Workshop is adjourned.